I had a patient that was like asking me a lot of questions about radiofrequency ablation, and in that era it was just FDA approved in the US, and this patient in particular had done her research pretty well, and so that sort of triggered me. I'm like, well, I probably should look into this a little bit more if the patients are seeking this treatment.
The doctor has to take it upon themselves to go learn this. It's not like you're being trained like this in medical school.
And there's a lot of sort of friction to incorporate newer technologies into your practice, but this was one that really had some promise for the future and had a lot of benefit for the patient in particular.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Ryan Neilan, an otolaryngologist, head and neck surgeon practicing in Houston, Texas. He is the chairman of the Otolaryngology-Head and Neck Surgery Division at Memorial Hermann, the Woodlands Medical Center. He has been honored as a Vital's Top 10 doctor and received both the Patient's Choice Award and the Compassionate Doctor recognition. His peers have repeatedly selected Ryan as a Texas SuperDoc's Rising Star. Clinically, he sees the breadth of general otorhinolaryngology, utilizing multiple advanced and minimally invasive techniques. He is the Director of Interventional Endocrinology at Texas ENT Specialists and is the first head and neck surgeon in Texas to offer in-office radiofrequency ablation treatment for thyroid nodules. So Dr. Neilan, it's been about a year and a half since we last met at Johns Hopkins at a Thyroid RFA training course. So I'm really excited to speak with you today and hear about new developments since then. So welcome to the podcast.
Thank you for having me. So yes, I met you at the Hopkins course, which was sort of portion of it was didactic, and then there was the hands-on cadaver lab. I kind of had gotten hooked up there initially through actually a patient, which is sort of an interesting story.
Oh, wow.
But before COVID, I had a patient that was like asking me a lot of questions about radiofrequency ablation. And in that era, it was, just FDA approved in the US,
right.
Done in Korea forever. And this patient in particular had done her research pretty well. And honestly, like at that point in time, especially as a surgeon, like people don't come in asking about that. That was a first.
Right.
And so that sort of triggered me. I'm like, well, I probably should look into this a little bit more if the patients are seeking this treatment. And so, did some research, kind of got plugged in with the Stanford group, did a ground rounds that they had put on that was very nice. And from there had got put into the Hopkins course in Baltimore.
That is so awesome that you were prompted by a patient's urging of or interest in this procedure to take that upon yourself to go to that training and to learn that, because I know that it's pretty much always that sort of situation where the doctor has to take it upon themselves to go learn this. It's not like you're being trained like this in medical school and it's just part of your training, right?
Yeah, I mean, like medicine in general kind of has this paternalistic approach, and there's a lot of sort of friction to entertain and to sort of incorporate newer technologies into your practice. And this was one. We as you read journals, you come across many of these every year, but this was one that, especially after, talking with the people at Stanford and Hopkins, that really had some promise for the future and had a lot of benefit for the patient in particular.
I think that patients will find that so encouraging because in our community, I run the Save Your Thyroid community on Facebook. We currently have over, I think, 7,700 members. It is frequently being brought up by patients. Why isn't my doctor telling me about this? I'm asking them about it, but they don't know about it. And so I think that to hear that persistent asking is actually beneficial will be so encouraging to them.
And most of the patients I'm currently seeing in clinic, they've seen somebody else usually. Houston's a big city. They've usually seen someone that maybe is a little bit closer in their community. They may have only been offered surgery. They may themselves have been asked about RFA and been stonewalled a little bit. Because again, if people don't have exposure to it and aren't the ones doing it, they're not going to offer it. And there's even, the primary care community, sort of the referral patterns. I mean, a lot of them they don't know about it. And so educating that frontline community practitioner has been a challenge actually in the city a little bit.
I agree. And I would love if we could develop some sort of systematic approach, for our patients in our community to be able to go to their PCPs and educate them. If it was some website they could direct them to, or a handout or something, because our community is intended for patients, we don't allow providers to come in there and participate. But we do. I agree. We need these primary care physicians educated on this. My primary care physician doesn't have any experience with it whatsoever. I'm her only patient who's undergone it. And that's common. That's a common experience of patients. So definitely they need to know about this, especially if they're going to be following up with patients who maybe have traveled a long distance to have their procedure and they can't continue traveling every 6 months to a year for a follow-up visit for an ultrasound. So yeah, I'm really glad you mentioned that. That's very important. And I would, if you have any thoughts about on your end on how to educate the primary care physicians, please let me know.
Yeah, I mean, we have revamped our website. I don't think that that's something that the primary care doctors are looking at. That often it's more targeted towards sort of patient education. I personally have, hand mailed a bunch of flyers with a bunch of information. We've tried to have some dinners, invite people to come and sort of hear us talk about, what we have to offer that's non-surgical these days. But even just a really short video, if you have an email listserv of some sort, I mean, you may have 20-30% of the providers click on it, but that if your listserv is big enough, that's a decent amount.
That's a great idea. I actually have a Substack where I have a blog on Substack, and that sends out an email to everyone who's subscribed to it. As you said, I could make a video explaining, this is what PCPs need to know about this procedure that your patients are wanting and asking for. And, a number of my subscribers on that blog are actually physicians. So it could be that they could forward that on to their PCP colleagues. And, so you just amazingly helped me elucidate some kind of plan here. I appreciate you kind of taking me down that road.
We've been trying, grassroots with the mailed flyers and, bundt cakes and cookies and all that stuff. That's how you get through the nursing staff to the providers, or the cookies.
Let's circle back and give a little bit of a background on yourself for the viewers who are not familiar with you. Tell us about why you chose to become an ENT physician, and that big word I mentioned in your introduction, otorhinolaryngology, that I actually did not stumble over.
Yeah.
Tell us a bit about what that is and how that, comes into play with what you do every day.
So otorhinolaryngology, everybody calls it ENT, ear, nose, and throat. That's sort of the easy way to say it. Was something that I kind of stumbled in upon. I think that, when you go to medical school in particular, in your mind, you have this idea of, what kind of doctor you want to be. Mine was pediatric cardiology. And
wow.
I look back on that, and, now that I'm like overly educated on all the stuff, I don't know why that was, in my head at all, but that was what was there. And then, the first class you take in medical school is anatomy. And the first day in the cadaver lab, like I knew that surgery was something that I wanted to be a part of. And so, the anatomy of the head and neck's very complicated, lots of nerves, vessels. We do a variety of procedures just based on the locations that we sort of oversee or from a patient standpoint. ENT, we have a lot of gadgets, so it's pretty techy. Scopes, cameras, drills, now RFA needles. And so, the variety keeps it interesting. And so I did pretty much all of my training at the University of Texas, finished my residency at UT Southwestern in Dallas, and have been in Houston practicing privately for the last 10 years. My practice in Houston is broad. I do all kinds of surgical procedures, pediatrics, nose and sinus procedures. And then thyroid cancer, benign thyroid issues, parathyroids, neck lymph nodes, things like that. Over the past couple of years, my practice has sort of steered more to in-office type procedures. And that's when RFA came along, I thought it was going to be a really good fit for not only my patient population, but also just for our practice in general.
Being a surgeon, I love to ask this question to surgeons. What as a surgeon makes you think, I want to adopt a non-surgical procedure?
Well, if you do enough of the surgeries, you start looking for things that are better, right?
Oh, that's awesome.
I love to operate, right? That's, why I, did this. But when we talk about, neck surgery in general, from most of my patients, the main complaint is the scar. People don't want scar visible on the neck. Scars for thyroid surgery used to be quite large. They've shrunken over time, thankfully. Mm-hmm. But they're still noticeable for the patient. And then just the recovery. It's a weak recovery. There's risks involved, such as, nerve injury, hypocalcemia, hypothyroidism, after removing, a lobe of the thyroid. And so just watching people sort of go through that over time, through this patient and through some training courses, stumbling upon this, it just seemed like a much better alternative for the properly selected patient.
That is a very common answer that I get from surgeons who provide RFA, is that they've seen what it can do to people's health after thyroidectomy. And obviously, I want to say thyroid surgery is not the end of the world if you absolutely have to undergo thyroid surgery. And there are so many patients in our community who feel that way. And I used to be, I'll just kind of digress for a moment. I used to be like so against the idea of thyroid surgery to the level of that I think it was unbalanced. Now, granted, I had a very good reason for that perspective, which was that I underwent surgery at 18 years old, almost 19 years old, twice within the span of a week for a knee injury that the surgery went horribly wrong. I had a systemic staph infection and was in the hospital for a week, almost died. And I've been disabled ever since. And it's just been one long regret, one big long period of regret of why did I not make an informed decision or take my time to make that decision? It wasn't urgent or an emergency. And then I ended up suffering all of these consequences. And so over the 4 years that I've been doing this, I've learned a lot. I've spent a lot of time with physicians, gained so much respect for physicians because unfortunately, when you go through years of multiple bad experiences with physicians, sometimes you kind of lose a little bit of, the respect that most people have for them. And so I've kind of come more towards the middle, I think, now than I was in the beginning on my opinion on surgery, which is that, as you said, in the appropriate patient, this is a great procedure. It's not for everybody. If you are going to have a surgery, you really need to, as I was saying about my experience, do your research, make sure you've got a great surgeon who's got a high volume of surgeries under their belt. Make an informed decision. Don't just, plow into or dive into that decision, especially if you're going to have a total thyroidectomy and you will have to be on medication for the rest of your life. That's something you really want to go into that educated about that decision. So,
one of the things that as a surgeon that we want to accomplish for our patients is the ability to offer somewhat comprehensive care. And so the more tools you have in your box to offer and to treat patients, sort of we don't have to send them elsewhere, right? We want to be able to take care of them, from the time they come in to see us, no matter what their needs or issues are, to accomplish their goals.
I love that, and patients do too. It's a common complaint when they come to our community. They'll say, well, I have to go here for this and I have to go here for that. And I'm bouncing around from, one doctor to another like a ball in a pinball machine. And so, offering everything that patient needs in your clinic under your care is tremendous. So let's go back and talk a little bit about the RFA training at Johns Hopkins last year. Tell me a bit more about what you learned at that training and how did it prepare you practically for what you're doing in your office with RFA?
So the Hopkins course was really my first, formal didactic type exposure from an academic standpoint. And so a lot of it was about sort of the physics behind RFA, the fact that it's an electrical field. Some of the patients tend to think that the radio frequency and radioactive iodine are the same thing.
Right.
And so really, knowing that it's different and how the physics of the probe works and distributes the energy to the tissue. In our practice as surgeons, we do a lot of ultrasound guided fine needle aspirations. And so this is sort of a similar skill set, but just more advanced and more three-dimensional in the way that you need to work through the nodule to address it three-dimensionally. And then the Hopkins course was great for just the cadaver experience. They had a really good industry support there, and just being able to talk to some of the people that had been on the forefront of developing this, in the United States and adapting it from Korea and Europe. Was just nice to get their sort of pearls and pitfalls and things like that. And then some of those guys, I actually went to the Brazil course.
Oh, you did?
So that's like the master class down there. And so there are some didactics, but also they at their state hospital in Rio de Janeiro actually have hands-on, patient care. Where you spend a whole day just doing these procedures, supervised by the best of the best, helping out their local community there. And so that was probably the greatest experience I've had with RFA so far.
That course, I've never been down to see it, but I've heard so much about it. It sounds like an incredible opportunity to learn. And the Hopkins course, I've actually been to twice. I love that course. I mean, obviously, I don't have the same perspective as you being a patient, but from my perspective, seeing what you guys are doing and all of the experts that they bring to explain every aspect of this procedure, it's just a really wonderful learning opportunity for you to be able to get a very good foundation. So I'm not endorsed by them or endorsing them. I just, objectively see that course looks like a really amazing learning opportunity.
Yeah, I mean, if you're going to, it's really, Baltimore's a lot easier to get to than Rio.
Right.
You're starting out and want to check out a course, like that's the one to do.
Maybe one day I'll get to get into Rio. That would be cool.
Okay. I highly recommend it. It was such an amazing place and course, and just being in that hospital down there and their healthcare system and kind of seeing what the conditions are and being able to help out a little bit was great.
So when did you actually get started doing RFAs in your clinic?
And so really, after the Brazil course, we had, Rudy come down and get us set up from a updated ultrasound standpoint and the, RFA generator and things like that. And so after that course, really started offering this to patients. Fortunately, my first patient was a nurse at the hospital, very understanding of like what was going on, but it was someone that, had known for a while, was trying to avoid surgery, available, sort of jumped on that opportunity. And so, we do these in the clinic, awake under local.
Right.
The procedure is, I try to tell patients it's like an extended biopsy, which they've all had at the time. It takes about 30 minutes and, they go home with an ice pack and they're at work the next day. And so we've been able to do probably about 10 so far in clinic. And it's like great to see them back. Really, like, as people should know, that final result takes about a year to occur. Our target is about 80% shrinkage of the nodule. It doesn't eliminate the nodule. But I've been surprised to see that almost everybody that we have done has had symptoms, whether it be cosmetic or compressive, right? 4 weeks, all of them symptom-wise have improved.
It's phenomenal. My experience with that was, I went from being able to look at this huge bulge in my neck, feel it every time I swallow, have trouble lying down and breathing. And within just a week, I started noticing it getting better. And like you said, within a month, it was tremendously improved.
It's especially the ones that are visible. You walk in that room for their 4-week post-op, and when you can't see it anymore, it's really gratifying. It's
life-changing. What about hot nodules? Have you treated any of those?
I've not treated any yet. Actively seeking some to treat. And so for hot nodules, sort of characteristically, the treatment has been radioactive iodine. They have to do that once or even twice. That treatment leaves you hypothyroid. So you're definitely looking at thyroid hormone replacement over the long term. Some of those patients that fail the radioactive iodine end up with a total thyroidectomy for their toxic or hot nodule. The benefit of the radiofrequency ablation, if it's really a single nodule, and we can tell that from some of the preoperative workup that we do, If it's really a single nodule that's producing this extra hormone for the patient, RFA is a really good option. Again, it's done in the office. We preserve their thyroid function through the modern ultrasound technology. We're able to tell at the end of the procedure, does the nodule still have blood flow or not? We want it not to at the end of the procedure, to make sure that we've gotten the job done. And so the data for that looks really good. I'm trying to get some of my partners to send me some of those patients to do, but haven't had one yet.
The ones that are smaller have such a great outcome. The bigger ones, we don't see as much resolution, but they can have improvement.
Yeah, I mean, there are some patients that have just multiple toxic nodules.
Right.
Your ability to really go in and treat, 6 nodules that are hot at the same time and get all of them. Those are patients that probably are better suited for the radioactive iodine, which is, that's the test of time is sort of the primary treatment for that.
Currently, you're doing benign nodules only?
We will do papillary thyroid nodules.
Really? Okay.
I haven't had one in the States. At the Brazil course, and we've done one there. But for the smaller, like micropapillary thyroid carcinoma, if it's small enough, I think that's a great option for those patients. The larger ones really probably still need a lobectomy.
Right.
There's a lot of people trying to publish on that research-wise. As that data continues to develop, I think more people will be more open to adopt that. That and also, recurrent neck lymph node metastases is another one looked at, especially patients that are, poor surgical candidates for revisions and things like that. When these nodes or even in the thyroid, some of this residual tissue pops up years later. Yeah. Sometimes would be good candidates. There's all kinds of utility for this particular technology.
Let's go back to cancer for just a moment, because that's becoming a really hot topic in our community. And in just about a month and a half, I'm gonna actually be hosting 2 sessions for the THICA conference on thermal ablation options for thyroid cancer and metastatic lymph nodes. So what are the parameters for treating thyroid cancer? You kind of alluded to the size. So let's talk about the size, location, type, all of those things for any new viewers who are looking into this information.
Most people would say currently, it's something that we're looking at for the papillary, which is the most common variant of thyroid cancer. You're looking for ones that are a centimeter. You really want them to be small so you can treat them thoroughly. I think that will expand over time as people get more comfortable with it. You really want it to be a single nodule in that thyroid lobe. Papillary does have a tendency to have some multifocal potential. So if there's multiple nodules on one side, they're probably still better off with a lobectomy if it's under 4 centimeters. The follicular and the medullary variants, those are things that I don't think people are tackling yet. Follicular over time, possibly, but I think really at the current moment, from a thyroid standpoint, people are really tackling the papillary variant.
And I'm always told that the location needs to be really sort of in the middle of the lobe so that there's plenty of room to treat around the outside.
Yeah, with the benign nodules, we're just trying to get a shrinkage, right? We're not trying to destroy all of that tissue. And so really it gives us more of a buffer, especially the larger nodules. You've got plenty of room to shrink most of it without trying to get to the periphery. With the papillary, you really want to make sure that you're destroying the whole nodule, including some of the normal tissue around it. And that's where that color flow Doppler comes into play on the modern ultrasounds to be able to check that. But yeah, if those nodules are particularly, deep and medial where the recurrent laryngeal or sympathetic nerve chain is, or out lateral towards the carotid, those are areas that aren't real favorable at the periphery just because of some of the structures involved.
Talk a little bit about extrathyroidal extension and why that's a problem.
With the radiofrequency, you can only be sure that you're tackling thyroid tissue in the thyroid safely, right? Mm-hmm. And so, some of these more aggressive tumors do extend out into the musculature, or even into the lymph nodes sometimes. Those are patients that need a surgical treatment where you can control margins, and if you need to remove some of the muscle, you can, and you can make sure that margin is free of disease going forward. You don't have that capability with the RFA technology.
And then with the metastatic lymph nodes, just to educate the viewers, that is typically only appropriate after the patient has had a thyroidectomy and then they have a recurrence. Can you talk more about that?
Yeah, for both, metastatic lymph nodes, whether they're thyroid or even just, other head and neck cancers like squamous cell carcinoma. These are people that have, undergone previous treatment and this has popped up later. A lot of the patients, if it's, one large node, if they're good surgical candidates, if they're healthy, a lot of times we will try to re-excise
Right.
the surgically. Some of the patients that are either, older or are less optimal candidates for anesthesia, this is a nice way to tackle those recurrences. Typically, you're looking for patients that have, minimal recurrent disease. You want,
Right.
one lymph node under 2 centimeters. It's really not feasible to get in there with the RFA and try to treat multiple, clusters, conglomerates of lymph nodes effectively.
Right.
That probably benefit more from surgery, in my opinion.
Anyone watching this video who wants to learn more about thermal ablation treatments for thyroid cancer, please register for the upcoming THICA conference. Registration is free and can be done on thyca.org. I know Europe has guidelines on RFA, but the US ATA, we don't have guidelines yet, right?
There have been some published. So for a
Okay.
while, we're just going off the Korean guidelines from 2017. More recently, I believe it's the American Head and Neck Society, which is a lot of people from the Hopkins and Brazil and
Right.
sources, have released some North American guidelines. And so those are published and out there in the Head and Neck Society website if people are interested in that.
I will find that, link it in the description, because I know a lot of people want to know what is the guideline for this. And the parameters and all that. So thank you. What are your plans related to RFA in the future?
Really just to expand the practice. It's pretty new. It's one of those things where, word of mouth starts to go around and people, start trickling in to see you for this in particular. A lot of people are just interested in the information. They've seen somebody else about surgery, want to know what else is out there. And I think as time goes on that this will become a modality, for the benign disease in particular, that's just more highly utilized. In my experience, there's a lot of surgeries that can be avoided with the use of this technology. And I think it's just going to become more widespread.
There's a statistic that I quote frequently, which is that every year in the US, 150,000 thyroidectomies are performed. And out of those 150,000 surgeries, 2/3 are for benign disease. I would love to see, I guess maybe in about 4 years, it'll be 10 years since RFA was FDA cleared in the US. I would love to see how much that number has shifted towards the non-surgical approaches and how many patients were actually able to avoid that surgery. So I don't know how we'll obtain that information, but that would be amazing.
I'm sure it'll be possible, right? That potential is definitely out there, but it does depend on patients at this point trying to seek it themselves.
Mm-hmm.
The other side of that coin is just providers willing to adopt new technology and to change their practice patterns from what they're used to doing on a daily basis.
Exactly. Well, hats off to you for taking that on. So I have a few questions from the SYT community. Number one is about insurance. So we know oftentimes insurance doesn't cover RFA. However, we are seeing some people who are having success. The reason for that is the lack of a CPT billing code. First of all, have you had any patients have insurance coverage for their procedures? Secondly, do you have any updates on an RFA CPT code?
Yeah, so I've had one patient out of the 10 that her insurance did reimburse her completely for the procedure. Insurance is the big friction with this, and that's why the barrier to care is it's cost prohibitive just based on utilizing the technology for a lot of patients. And so, the insurance is we have a pretty robust billing office, and so we help people fill out paperwork to apply to their insurance. There's sort of a special form that they can fill out. The form, like even if they approve it, it does typically reimburse them after the fact.
Right.
And they don't tell you what your reimbursement is until after the fact. And so it's a bit of a roll of the dice with some of that. We've offered people care credit and payment plans and things like that.
Oh, that's awesome. Yeah.
Try to make it more feasible because, again, the insurance is currently the barrier. I've been told that recently that there was a code submitted for RFA. That is not a quick process.
Right.
And so, it may take years for that to be approved, but that's one of the things. As soon as that's available and out there, the actual number of these done will just boom.
Exactly. I agree. So what I frequently tell patients to consider when they're thinking about out-of-pocket costs for RFA, versus the insured costs for a thyroidectomy. Anytime you have a surgery, even with insurance, there's going to be out-of-pocket costs. There's always going to be expected and unexpected out-of-pocket costs. And then you're going to have other costs that come along with it that you're going to, with your health and whatnot. So, and then there's the time aspect of it as well. As with RFA, if you were to pay out of pocket cash, that number may seem very high, you may get a little bit of sticker shock. However, if you were to do a side-by-side comparison of your out of pocket for both a thyroid surgery and an RFA, you might actually find that your out of pocket would be very, very similar. I always tell patients, don't immediately, if you're concerned about that aspect of having the procedure, don't dismiss it immediately just because of the not being able to use your insurance on it, because that may not actually make that much of a difference right now.
When we talk about surgery in general, there's the surgeon costs, there's the anesthesia costs, there's the facility costs. Particularly the facility costs for surgery, just to the operating room, are very high. And so when you look at people's out-of-pocket expense from a radiofrequency procedure, it's a few percentage points compared to what the estimation of benefits would be on, let's say a total thyroidectomy type procedure. And so yes, that's definitely something to think about. And we try to communicate that to patients, but they really sometimes just want to do what their insurance wants them to do because they pay for the coverage, right? They figure they might as well use it. One thing about RFA is a lot of the insurance companies will allow you to use your health savings account for that. So that's one way to decrease the cost. The other thing is some of them will, even if you pay out of pocket, the amount that you pay, they will count towards your deductible. And if you're going to have surgery of any type, and in our world, even ear tubes, if you're going to have surgery of any type, you're going to meet your deductible. That's just a certainty. And so it's definitely something to consider when selecting, is it worth it from a financial standpoint or not? Most of the time the numbers, if you really dive into it, make sense still.
The only time I've ever met my deductible within recent years was the 2 times I had RFA. I never met my deductible. It's so high. And I know that happens to a lot of patients with their, high deductibles these days. So it's definitely worth considering the cost benefit analysis on both sides and comparing the numbers.
People also don't consider their time away from work. People with RFA are back at work the next day. They're, I let them go to the gym. I don't know if everybody does that or not. But really there's the downtime is that afternoon and that's it. When we talk about a surgery for the same problem, it's at least a week off on people, just depending on how they respond to anesthesia and recover. Sometimes it's 10 to 14 days. And so that time away from work also has financial implications for a lot of the patients. And that's not something that a lot of patients I think consider upfront when they're comparing the two modalities.
The majority of our population in our community are young women with children. And if you're a working mom or a stay-at-home mom trying to care for your children, taking off weeks at a time is very difficult. I remember when I came home, I went to Virginia for my RFA procedure because I live in North Alabama, and at that time there were no providers here. Then when we came home, I was pretty much okay with handling, the care of my children. I didn't have to I was tired, but I didn't have to have bed rest or anything like that for, the coming days. Now, I've never undergone thyroid surgery, but I can't even imagine being any worse off and still having to take care of my children or go to work. So that's definitely a factor to consider. Okay, so next question is, do you treat multiple nodules at one time, or would you spread that out across multiple treatments? And maybe talk a little bit about the reasoning behind treating one side at a time versus treating both sides at the same time.
So, currently, if the nodules are on the same side, I will treat them at the same time. And it's real common. People have 2 large nodules. They almost come together. We just kind of treat it as one larger nodule. If they're 2 large nodules on opposite sides, I would stage that procedure. And the reason for that is that, after you introduce this thermal injury into the thyroid to get the nodule to necrose over time, that thermal energy causes some edema or some swelling, especially that next day or so. And the thyroid is wrapped right around your airway. And so we don't want to ablate both sides, particularly larger nodules, at the same time. because we don't want to cause any airway compromise. We don't want you, to have shortness of breath, end up in the ER because of that rebound swelling that first day or two. And so currently, I think most people do the same, is one side at a time.
In my particular situation, I had a really big nodule. It was between 65 and 75 milliliters, and I did have some swelling afterward, but it was all external, thankfully. And I didn't have any compression symptoms, but I can't imagine if I had had that on both sides, what that would have felt like. So I definitely see the reasoning behind staging in that situation.
To piggyback onto that comment, the other thing that patient should know is that most nodules can be done in one treatment. If those nodules are large, and I always tell patients, we may have to do this again in a year. Which really isn't a big deal because it's such an easy thing for them to undergo in the office. But the larger ones, a lot of times there's residual volume that requires us to treat them again to really get the shrinkage that we want, which again, it's easy to do, but patients need to know that up front that
definitely
you've got a pretty big nodule. We'll see what the first year brings us, but if we're still having symptoms, like this is one that we may need to do again in a year to really get you to the point where you're not having those compressive symptoms anymore.
In my particular situation, 20% of my nodule was too low to get to. It was behind the collarbone. So he intentionally did this in a 2-stage approach where he treated the top part, and then as it rose up from the shrinking, that bottom part became accessible. And so we always tell patients, if your nodule is 6-7 centimeters, you're probably going to need to have 2 treatments. Plan ahead for that, but you're also going to see improvement in that first treatment. So
I've actually had some other providers in my group and in the area ask if I would be willing to perform an RFA on their patient just to shrink it down so that it's easy for, if they still need to operate, it's easier for them to get at, because we really during surgery want to avoid that substernal site, and there's nowhere else for those nodules to go as they get bigger. And so I've had people request, if I could do that just to, make the surgery easier in the future.
That is incredible. I asked a question like that to Dr. Keith Forwith when I interviewed him in 2021, if that was something that he thought would happen down the road. And so it's very cool to hear you say that. And it makes sense to me, that a surgery to remove a mass would be much easier if that mass was reduced by 20, 30, 50%. So
particularly if it pulls it up out of the chest space. I mean, that substernal component is what we're worried about surgically most of the time.
My doctor told me that my aortic arch was, kind of close to mine. And, that's kind of scary when you think about like something being that close to such a main vessel. Mm-hmm. You don't want to get close to those things.
No, I mean, and there are some very, very rare cases where we actually do the thyroidectomy in conjunction with a cardiothoracic surgeon, because we'll have to split the sternum like an open heart procedure to get down there to remove it safely. Not very common, but happens.
Yeah. When I was researching having to have my thyroid removed before I knew about RFA, I was researching substernal goiter surgeries, and I read about that, and that terrified me.
Appropriately so.
Obviously, in some patients, it's necessary, but the idea of having my chest cracked open and all of the things that would come along with that, I couldn't go there. So I'm really grateful that I was able to have RFA. Okay, next question. Let's talk about monopolar versus bipolar RFA electrodes. Are doctors in the USA keeping up with the newest international techniques regarding that?
I would say that most people in the US are doing monopolar. That's sort of what's available, and that's the most studied and utilized. The difference between the two, monopolar, the electrical current does travel through your body to some degree. And so we have to place grounding pads on the patient's legs to absorb that energy and sort of take it out of the body. Bipolar needles or devices, the energy is transmitted from one part of the needle to the other, so it stays sort of within the area. For patients that have like pacemakers and things like that, that's a huge consideration. For most of the population, I think that most of us would say that it doesn't really make a difference. But I believe that most people in the US are doing monopolar just because that's what's most studied and available.
Last question. This patient says 1 year after having a successful RFA and a cancerous nodule based on ultrasound, what are the regular health checks to do, the must do and the nice to do to avoid possible problems in the future? So talk about follow-up after RFA of a cancerous thyroid nodule.
Yeah, these are patients that are, not only going to have, multiple ultrasounds to follow this area along. We're usually also following some biochemical markers with the thyroid just to make sure that, over time we're not seeing some of those numbers increase. That can be an early sign that, there's something growing and we may need to take a deeper look. Some of these patients, depending on the type of cancer, more so than just ultrasounds, may be getting CT scans at some sort of a regular interval. They may also be getting PET scans to check the rest of the body at some sort of regular interval. Post RFA, there's not real guidelines on that sort of when and how much to do that, but there definitely will be, some monitoring that goes on for multiple levels.
And is thyroid globulin something that's worth checking in an RFA patient? I know that's something that's checked after thyroidectomy.
Only in patients that have previously had a total thyroidectomy for their initial surgery. And if they've had RFA, it's been for, a one node recurrence somewhere. And so really that's only useful if patients have undergone, a total thyroidectomy at their initial cancer procedure.
So that concludes all of our questions. I've really enjoyed getting to know you and talking through all these things. Do you have any final comments or thoughts you'd like to share with the audience, Dr. Neilan?
I would just say that if there are people outside of the Houston area that are looking for this, to still reach out to us. A lot of the initial consultation can be done over the phone or telemedicine, if we have the appropriate records to review at that time. And that way, patients are just coming for, the one day for their procedure and can go back. I wouldn't let distance, as you know, right? I wouldn't let distance dissuade you from pursuing this type of a therapy if it's what you really want and you're a good candidate for it.
Definitely. I wholeheartedly agree. Patients that want to learn more about you can reach out to you online through your website, and your contact information I'll put in the description below.
Thank you so much for having me. Appreciate it. Have a wonderful day.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me, Jenna Gunn. Never forget to educate yourself and be your own advocate and save your thyroid.